My talk is really looking into how surgery is going to be part of the multidisciplinary team moving into the sort of next generation of oncological management of locally advanced but resectable lung cancer. We've taken quite a lot out of the Getting It Right First Time report, which came out obviously as a draft in January this year. And one of the key findings that we are interested in really is the provision of equal cancer care throughout the country, and the discrepancy based upon region and based upon outcomes in terms of resectability, in terms of resection rates, and the known survival outcomes associated with patients who have locally advanced but potentially curative disease, which is actually not then offered radical treatment. And so one of the things that we were quite keen on in terms of the local regional disease initiative is to try and improve the provision of cancer care and improve and streamline the MDT performance across the country. And so what we were interested in potentially providing is looking into the GIRFT recommendations of a second opinion MDT. And for those patients not offered radical treatment, but who have potentially curative disease, so those sort of early stage lung cancers who are perhaps in patients who are high risk in terms of patient factors, in terms of preoperative FEV1 and lung volumes, and in terms of potential resections, so complex resections, but certainly doable resections. And so really focusing on resectability and operability, and looking into the reasons why patients don't get equal care. And moving that forward, how we would provide and what the structure of a second opinion MDT might be, and how we would streamline from peripheral to a central second opinion MDT. And really that's one of the second points coming out of the GIRFT report, is that whilst we should be providing that second opinion across the Cancer Alliance, there should be a pathway for providing that second opinion. Part of my talk also goes into then looking at the rationale and the reasoning behind potentially different outcomes at different MDTs. And there's been some interesting work done by teams at King's College looking at the decision-making within MDTs. And we know that peripheral MDTs tend to be very long. Certainly, I've been at peripheral MDTs that have been 70 odd patients long and gone on for 4 to 5 hours. And really quite frankly, the decision-making obviously deteriorates throughout the process. No one can focus for that long a period of time. And we know that those meetings also tend to include some non-cancer patients. They intend to include patients who perhaps don't have adequate clinical data provided with the presentation. So there's a lot of factors, and it's not necessarily the fault of the referring hospitals. It's just the fact that it's a complex system and nobody wants anybody to slip through the net. But that isn't always the best approach in terms of providing definitive and the best possible cancer care for patients. Moving that onwards, I then move on in the talk to talk about those patients who might be discussed at this kind of MDT. And one of the things we were interested is in the provision of multimodality therapy, in terms of trimodality or quadrimodality therapy, and how we would time surgery with other treatments such as chemo or radiotherapy. And I've looked a little bit at the outcomes in terms of surgery post-chemo radiotherapy, and then looking at the way in which we provide surgery. And certainly we're moving towards a lot more minimal access surgery. And as surgeons, we now pretty much provide minimal access surgery as first line. Even for more advanced disease, we know that we're able to provide good lymph node clearance through a minimal access approach, for example. And with the advent of robotic surgery now, we have a much better ability to get to those kind of more complex tumors. The dexterity, the 3D vision provided by the robotic systems is much superior to video assisted. And then the ability to use adjuncts such as the indocyanine green and the Firefly systems with the Da Vinci as an example, to be able to localize segments, to localize nodules. And so all these things are really exciting moving forward with the sort of evolution of robotic surgery. And really then just sort of provided an update as to how we've evolved, because we're 28 UK centres, and at the end of this year there'll be, at this point in this year, there's around 10 centres providing robotic surgery. And by the end of this year, we'll be looking at 14 UK centres fully on board with robotic thoracic surgery. So that approach to increasing resection, increasingly more complex resection through a minimal access approach, is also then improving in terms of patient recovery, patient outcomes, and hopefully reducing the time to adjuvant treatment in those patients with more complex disease that need it.